Hypomagnesemia is a prevalent yet often undiagnosed electrolyte imbalance that demands attention from healthcare professionals. This condition is characterized by serum magnesium levels falling below 0.7 millimoles per liter, indicating a deficiency in this crucial mineral. Magnesium's importance cannot be overstated, as it plays a vital role in over 300 enzymatic reactions within the body. These reactions span a wide range of physiological processes, including energy production, protein synthesis, muscle and nerve function, and blood glucose control. The ubiquity of magnesium in cellular function underscores the potential systemic impact of its deficiency. Signs and symptoms of hypomagnesemia. The clinical presentation of hypomagnesemia can be insidious, with symptoms ranging from mild to severe, depending on the degree of deficiency. Common manifestations include nausea, vomiting, lethargy, muscle weakness, and drowsiness. These nonspecific symptoms can often be attributed to other conditions, contributing to the underdiagnosis of hypomagnesemia. As the deficiency progresses, more severe symptoms may emerge, including tetany, tremors, agitation, vertigo, confusion, cardiac arrhythmias, and in extreme cases, seizures. The neuromuscular and cardiovascular systems are particularly vulnerable to magnesium depletion, explaining the diverse array of symptoms. Healthcare providers must maintain a high index of suspicion, especially in patients with predisposing factors such as chronic gastrointestinal disorders, alcohol use disorder, or those on certain medications. Causes of hypomagnesemia. The etiology of hypomagnesemia is multifaceted, encompassing various physiological and iatrogenic factors. Gastrointestinal losses represent a significant cause, with conditions such as chronic diarrhea, vomiting, and malabsorption syndromes leading to substantial magnesium depletion. Certain medications can also induce or exacerbate hypomagnesemia. Notable culprits include proton pump inhibitors, PPI, which reduce magnesium absorption, and diuretics, which increase renal magnesium excretion. Other medications like aminoglycosides and immunosuppressants can also contribute to magnesium wasting. Renal losses of magnesium can occur in various conditions, including diabetes mellitus, alcoholism, hypercalcemic states, and renal tubular disorders. Additionally, redistribution of magnesium, as seen in refeeding syndrome among malnourished individuals, can lead to acute hypomagnesemia. Understanding these diverse etiologies is crucial for both prevention and targeted treatment. Diagnosis of hypomagnesemia. Diagnosing hypomagnesemia requires a comprehensive approach, combining clinical acumen with laboratory investigations. The cornerstone of diagnosis is a thorough patient history and physical examination, which can reveal risk factors and characteristic signs of magnesium deficiency. Serum magnesium levels are the primary diagnostic tool, with normal ranges typically between 0.7 to 1.0 millimoles per liter. However, it's important to note that serum levels may not always accurately reflect total body magnesium stores, as only 1% of total body magnesium is found in the extracellular fluid. In cases where the etiology remains unclear, a 24-hour urine magnesium test can be valuable in assessing renal magnesium handling. A fractional excretion of magnesium exceeding 2% in the setting of hypomagnesemia suggests renal magnesium wasting, pointing towards a renal cause of the deficiency. This comprehensive diagnostic approach allows for more targeted and effective treatment strategies. Treatment of hypomagnesemia. The management of hypomagnesemia is tailored to the severity of the deficiency and the presence of symptoms. For mild to moderate cases, oral magnesium supplementation is typically the first-line treatment. Common preparations include magnesium aspartate and magnesium glycerophosphate, which offer good bioavailability. In severe cases, or when patients are symptomatic, intravenous magnesium sulfate therapy is often necessary, requiring close monitoring in a hospital setting. The dosage and duration of treatment depend on the severity of the deficiency and the patient's clinical response. Crucially, Addressing the underlying cause of magnesium depletion is essential for long-term management. This may involve adjusting medications, managing gastrointestinal disorders, or optimizing the treatment of chronic conditions like diabetes. In cases of diuretic-induced hypomagnesemia, where diuretic therapy cannot be discontinued, consider adding a potassium-sparing diuretic like a milloride, which can help conserve magnesium. Dietary considerations. While supplementation is often necessary for acute management, encouraging patients to consume magnesium-rich foods is crucial for long-term health maintenance. A diet rich in magnesium can significantly contribute to maintaining adequate levels and preventing recurrence of deficiency. Excellent dietary sources of magnesium include green leafy vegetables such as spinach and kale, nuts, particularly almonds, seeds such as pumpkin seeds, legumes, whole grains, and even dark chocolate, with at least 70% cocoa content. Educating patients about these dietary sources empowers them to take an active role in their health management. It's important to note that dietary changes alone may not be sufficient to correct severe deficiencies, but can play a vital role in preventing future occurrences and supporting overall health. Monitoring and follow-up. Effective management of hypomagnesemia extends beyond initial treatment. Regular monitoring of serum magnesium levels is essential to guide therapy and prevent complications. Generally, levels should be rechecked after 5 to 7 days of replacement therapy. However, it's crucial to understand that serum levels may normalize before total body stores are replenished. Therefore, continuing replacement therapy for an additional 2 weeks after achieving normal serum levels is often recommended, especially in patients with normal renal function. This extended treatment helps ensure complete repletion of magnesium stores. During follow-up, it's also important to be vigilant for signs of hypermagnesemia, particularly in patients with impaired renal function or those receiving high doses of magnesium supplementation. Regular monitoring and appropriate dose adjustments can help maintain optimal magnesium levels and prevent complications. Key takeaways. Hypomagnesemia, though common, often goes unrecognized due to its subtle and nonspecific presentation. Healthcare professionals must maintain a high index of suspicion, particularly in at-risk populations. Recognizing the signs and symptoms, especially in patients with predisposing factors, is crucial for timely diagnosis and management. The diagnostic approach should combine a thorough history and physical examination with appropriate laboratory tests, including serum magnesium levels and, when necessary, 24-hour urine magnesium excretion. Treatment strategies should be tailored to the severity of the deficiency, addressing both acute repletion and long-term management. This includes not only magnesium supplementation, but also identifying and addressing underlying causes. Ongoing monitoring of magnesium levels and providing long-term management strategies, including dietary modifications, are essential for preventing recurrence and ensuring optimal patient outcomes. By adopting a comprehensive and collaborative approach to hypomagnesemia management, healthcare professionals can significantly improve patient care and overall health outcomes.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.